Our next speaker will be Dr. Seiichiro Abe, who is from the National Cancer Center in Japan. He's a world-renowned expert interventional endoscopist with skills in ESD. We actually sent our faculty to him from Los Angeles to learn and teach everyone. He's been an editor of many journals. He's now one of our associate editors for gastrointestinal endoscopy as well. It's a great honor and privilege to introduce him.
Thank you so much for your kind introduction. And it is my great pleasure and honor to be here. First of all, thank you so much for having me, Juha and Loeb. So my talk today is endoscopic resection and treatment outcomes of early gastric cancer. Actually, yesterday, so we celebrated this great success of this Congress 1 day in advance. We have a great friendship, but actually no COI to be disclosed. Okay, here's the outline of my lecture. I'd like to share with you the clinical indication for early gastric endoscopic resection and treatment outcomes gastric ESD and curability assessment and follow-up. Endoscopic resection is a minimally invasive treatment option which allows us to save the stomach and stomach function. And endoscopic resection is a local resection without lymph node dissection. So the treatment outcome should be comparable to that of surgery. So endoscopic resection is generally indicated for the low lesion with low likelihood of lymph node metastasis. So how much should we accept the nodal metastasis? The answer is at the most 1% for T1A cancer, so-called high-grade dysplasia in the West, and 3% for clinically T1B cancer. Because a 5-year disease-specific survival of the surgery cases in Japan is 99% in T1A and 97% in T1B. And also, another indication is, of course, the lesion is amenable size and location to en bloc resection. And somebody still thinks the piecemeal resection, but it is no longer acceptable because of the high local recurrence rate. Here you can see the incidence of lymph node metastasis in surgery cases according to the histological type, depth of invasion, and lesion size. These four blue categories risk of lymph node metastasis at 0% with upper limit of 95 confidence intervals, less than 1%. These category was good indication for endoscopic resection. Based on the data, the first gastric cancer treatment guideline was published in 2016, and blue category and yellow category was indication for endoscopic resection. However, talking about these three yellow categories were expanded criteria, which was regarded as investigational treatment because of lack of the insufficient data or long-time follow-up and standard of care with still surgery. Based on the background, we have the two clinical trials. JCOG, Japan Clinical Oncology Study Group, conducted two studies, 0607 to expand the indication for endoscopic resection for differentiated type early gastric cancer, and 1009, 10104 to expand the indication for undifferentiated type early gastric cancer. As a result, both studies demonstrated excellent result, and excellent 5-year overall survival over 95%. Based on the result, so the indication for endoscopic resection is revised, and these three criteria has been upgraded to the absolute indication. Now, we can perform the ESD as a standard of care of these four categories. Endoscopic submucosal dissection, ESD, is a minimally invasive treatment which allows us to do an en bloc resection regardless of lesion size and location. we do inside and outside the lesion and dissect underneath the lesion. By doing so, we are able to remove the lesion in unblocked fashion. This is a prospective multi-center observational study to investigate the short and long-term outcomes of ESD for gastric cancer, J-Web EZC trial. In this trial, during the 2 years, 41 institutions enrolled early gastric cancer or gastric neoplasm. As a result, a total of 10,000 gastric lesions were enrolled. Unblocked resection and all-zero resection were 99% and 92% respectively, and curative resection rate was 82%. This was really consistent with other retrospective studies. Of course, we experienced some non-curative resection owing to unexpected tiny and microscopic deep submucosal invasion or ring vascular invasion. In terms of the adverse event, postoperative bleeding and intraoperative perforation were 4% and 2% respectively. Of course, most of them could be managed endoscopically without any surgical intervention, and emergency surgery was only 0.2%. However, the issue is longer procedure time. ESD is still a technically demanding procedure even for expert endoscopists. So one of the technical difficulties of ESD is lack of the traction, lack of the surgeon's left hand. To overcome the technical limitation, some traction technique is developed in Japan. So one of the technical developments is traction-assisted ESD. We normally use a clip line traction. A line are typical dental floss and tied to the end clip, and the clip is line to deployed to the edge of the specimen. When the line is pulled through the mouth, the submucosal space is well exposed with good traction. So I'd like to show you a case. This is a very extensive lesion located on the greater curvature of the upper gastric body, 8 centimeter in size, Paris 02A. Can you treat it endoscopically, or do you refer a patient to surgery? If you refer a patient to surgery, probably the total gastrectomy is well performed. For this case, ESD is technically much more technically demanding than the standard case, because we do endoscopy in left lateral position. The region is really submerged underwater. And also, it is very difficult to obtain the sufficient traction during the procedure owing to the gravity direction. So how do you do that? Okay, so I do ESD for this patient, so I'd like to show you the video. In retrolateral position, as you can see, the paddle is a problem, as the region is totally submerged underwater. In this situation, it is no longer possible to do ESD. So we change the patient position to right lateral position. By doing so, the water shifts to the other side. We can see the lesion very clearly. Using indigo carmines, we check the lateral extension of the margin and marking around the lesion like this. Okay, so the lesion water is shifted to the cardiac. We first mucosal incision using the needle-type device from the distal side, and also we also use the make the large mucosal flap using the dual knife to create the large mucosal flap of the distal side. And then we do a circumferential mucosal incision using the IT knife as well. But still, it is almost impossible to make the good traction. So we use traction-assisted ESD. We deploy the clip line to this distal end of the specimen. When we pull the span, As you can see, the submucosal space well lifted up with good traction. The following submucosal dissection is relatively easy. We can dissect the submucosa very efficiently parallel to muscle layer. The region is very extensive. The one clip retraction is insufficient, so the second clip is applied to the right side. Similarly, the submucosal dissections are well performed. We can directly inspect the submucosal space and efficiently dissect submucosa. And the third clip line is deployed. Very huge and extensive lesion. But we can do submucosal dissection very efficiently and safely. Finally, a small perforation made, but it doesn't matter. Small perforation is closed by end clip, no problem. So anyway, the umbilical resection was done, so huge mucosal defect is seen. So we are going to close the mucosal defect. Unfortunately, the overstitch device is not commercially available in Japan, so we close the defect using end loop and end clips, using the double channel endoscope. We anchor the end loop on the mucosal defect and close the defect by tightening the end loop like this. In this case, we use a 3 end loop like this. But totally, and complete closure was done. But procedure time is about 2.5 hours, like surgeon. Okay, so resected specimen will be the well-differentiated tubular adenocarcinoma, so-called high-grade dysplasia in the West, but specimen size was over 12 centimeter. Lesion is 87 by 70 millimeter in size, and umbilical resection was done. We can save the patient's life as well as the stomach. That is the endoscopic resection. But right now, there is a technical gap between United States and Japan. And so far, an ESD is performed by only the limited experts hand in the US, like Juher and Andy and Shai. He's not coming. Probably he's working so hard at the hospital, will be ready for the Friday night.
He does his cases on Fridays.
Okay. But actually, the technique of the ESD scale is dramatically improved in the United States. I attended the ASGE JGES ESD hands-on course at Chicago ITT Center this year and gave lecture and hands-on training in person. Surprisingly, the ESD scale of the training is dramatically improved. So I believe the technical gap is getting closer. Let's move on to the next topic, and curability assessment. Of course, it is very important to do umbilical resection and R0 resection, but more importantly, it is very important to evaluate the rejected specimen and assess the curability based on the rejected specimen. And if we can achieve the R0 resection without lymphovascular invasion, and these 4 category and the yellow category, we can follow up. That means a curative endoscopic resection. On the other hand, if the rejected specimen indicates a pink category equals C2, that means a non-curative resection with a potential risk of nodal metastasis, and standard of care is additional surgery. However, if we look at the data of the lymph node metastasis in additional surgery group, actually lymph node metastasis only 6%. So there is one clinical question. Is radical surgery necessary for all patients undergoing non-curative resection? This is a real clinical data in Japan from multi-center retrospective studies. A total of almost 2,000 patients were enrolled. About half of patients receives additional surgery or the other follow-up without any surgical intervention. That's a reality. So previously, according to the guideline, we uniformly recommend additional surgery for all patients, but this is the reality. If we compare the 5-year disease-specific survival between the radical surgical group and the follow-up group, the difference is only 1%, but statistically significant. So how can we interpret the data? Actually, the additional surgery is still standard of care based on the data. But it is a little bit difficult for us to encourage additional surgery for all patients. Based on the background, the study group stratified the risk of lymph node metastasis and develops a scoring system to predict the lymph node metastasis. In this scoring system, the 3 points were assigned to lymphatic invasion, which is a well-known risk factor of the lymph node metastasis, and each 1 point were assigned to the lesion size over 30 millimeter deep submucosal invasion, venous invasion, and positive deep margin. When the total score is 0 and 1, is classified as low-risk group, and the predicted potential risk of nodal metastasis is 2.5%, very low. On the other hand, if the total score is 5 to 7, it's a high-risk group, the predicted risk of nodal metastasis is over 20%. So that we can stratify the risk of lymph node metastasis according to this scoring system. Actually, this morning, a male patient came to me and consulted. So I got the permission from the patient. I'd like to share with you information. The patient is a male in 70. He underwent an ESD for early gastric cancer performed by expert hand. And the lesion is located on the antrum, the very small lesion. But histologically, the lesion invaded deep submucosal, 1,500 micron, without lymph vascular invasion. And the ESD is performed by expert endoscopists, of course, a clear deep margin. According to this criteria, the total score is 1 point. Only deep submucosal invasion, other were negative. So that this patient is classified as a low-risk group. So the potential risk of nodal metastasis is only 2.5%. So my standard of care is, of course, surgery. However, the follow-up is a good option. Of course, that really depends on the patient situation, but this is a good option, I think. I'd like to share with you a similar case. My case, an 80-year-old male with a history of cerebral hemorrhage. Performance status was 2. This patient has a very extensive lesion, 7 centimeter in size, on the lesser curvature of the upper gastric body. So we performed the extensive ESD like this. Specimen size was 9 centimeter. And unbroken R0 resection was done, and the lesion size is 7 centimeter, but depth of invasion is a slight submucosal SM1. According to the EQRA system, they are similarly, as a total point is 1 point, potential risk of 2.5 and 6.6%. So I precisely inform the potential risk of lymph node metastasis to patient, and the patient made a decision, decided to be followed up without surgery based on the risk of lymph node metastasis, and given the old age, limited life expectancy, and underlying disease. He survived over 5 years. By doing so, previously we uniformly encourage the additional surgery, but nowadays we have the risk stratification system. So we precisely inform the potential risk of nodal metastasis and discuss the patient about the further strategy. This is a new method. Finally, I'd like to share with you how we follow up the patient after endoscopic resection. This is a male in the 60s. We performed ESD for small early gastric cancer, so-called high-grade dysplasia in the west. Hope you can identify the lesion. Arm block resection and curative resection was done. 60 years later, this patient receives H. pylori eradication therapy, but the follow-up endoscopy identifies the 3 early gastric cancer. So we remove them. Furthermore, another 2 lesions was found 1 year later on chromendoscopy. You see it's a small shallow depressed lesion. We did ESD. So during his clinical course, he has 6 early gastric cancer. So during the follow-up, metachronous gastric cancer is one of the issues. Of course, my ESD allows us to preserve the stomach, but we left the very high gastric background of gastric mucosa. According to our data, cumulative incidence of metachronous gastric cancer, a 5-year cumulative incidence of about 10%, and over 20% for a 10-year follow-up. The annual incidence about 2%. More importantly, the cumulative incidence of metachronous gastric cancer linearly increase over time, even after 5-year follow-up. This is a very important point. And we analyze the data, and this is not a systematic analysis, but old age, male, multiple index ECC, and persistent H. pylori infection is a risk factor of metachronous gastric cancer. If the patient has any risk factor, we need to carefully follow up a patient. In terms of the risk factor, the last one, H. pylori infection, can be treated by eradication. Actually, H. pylori eradication is effective to reduce the occurrence of metachronous gastric cancer after ESD. So far, 3 randomized controlled trials done, 1 from Japan and 2 are from Korea. All of the 3 randomized controlled trials show the positive result. The occurrence of the metachronous gastric cancer is significantly reduced by the H. pylori eradication. So after endoscopic resection, if the patient has the H. pylori eradication, we highly recommend the H. pylori eradication for all patients if patient doesn't have any contraindications such as allergy. Here you can see my last slide, take-home message from Japan. The ESD is now the standard of care and technically standardized, and the gap between Japan and the United States is getting closer. And favorable long-term outcomes shown in many prospective studies, but we need to continue the lifelong surveillance even after 5-year follow-up. And last sentence, from 0 risk to without risk. This is not a management of COVID-19, but previously we need to follow 0 risk management strategy. We uniformly recommend additional surgery, but we need to investigate a further expanding indication and tailor the treatment for coming aging society. Thank you so much for your kind attention.